Okay, I'm going to finish up with drug abuse or substance abuse. Your author, the only thing that was really left in the textbook is to talk about treatments. And your author very briefly mentions Narcotics Anonymous and Alcoholics Anonymous and those kinds of programs where people get really social support from other people who are dealing with the same situation, dealing with the same losses, and sharing their experiences, reminding them that this is important for finding themselves in a better life and getting back their life to some extent. I have a few more things that I've included in here. It's just extra material, I suppose, but it's all really fascinating. And I actually took out a bunch of slides that I didn't want to take out. So I feel like I've kept in what I really think is interesting. So I had things a bit chopped up because I knew I was finishing those slides and then I finished the last few. I had some technical issues on whatever night that was, Sunday night and Monday morning. So these slides were in my next section, and so I did have the pictures of my people with on cocaine or off cocaine and craving, and then watching videos. But the first slide that I think is important for understanding aspects of craving and relapse is this one talking about the roles of the ventromedial prefrontal cortex as well as the dorsal anterior cingulate cortex, where if you're keeping track of how busy that structure has been in many of our discussions, and when y'all read about social pain, that was the same area that we were talking about. So the ventromedial prefrontal cortex, which again is now repeating because we've talked about it in emotions and in decision making and how emotions affect our decision making, but this plays a role in the learning of that extinction response. So when we saw the rat was lever pressing and not getting any cocaine, we saw an extinction. Well, that's what we're doing also when we're quitting a drug, is we're extinguishing a response. If we damage this region, it impairs extinction of a conditioned emotional response. We see stimulating this region inhibits conditioned emotional responses. And again, some of this, the performance of the response, part of that is because of the craving, right? So really what the ventromedial prefrontal cortex allows for is inhibiting that craving, that conditioned emotional response. And if we do extinction training, we activate neurons here. So if we are having problems with any kind of substance, it is a good idea to practice extinction and to build that ventromedial prefrontal cortex to be as strong as we possibly can. The dorsal anterior cingulate cortex, or the ACC or the DACC in this case, is involved in the reinstating lever pressing for infusions of cocaine. So if we go back to in our minds to that where we extinguished, we saw the reinstatement response. The rat was lever pressing a great deal for the cocaine. We saw the extinction once they were just getting saline solution. They were not lever pressing anymore. And when we gave them cocaine or some reminder cue of when they used to get cocaine with the lever press, they immediately started lever pressing again. Well, when they immediately started lever pressing again, that is the dorsal anterior cingulate cortex. So that is the craving that causes the relapse. And we can inhibit this area by injecting a GABA agonist, and that can prevent the reinstatement of the response. And so here is my picture of the people who are cocaine addicts and they're watching different videos. If we watch them, if they're looking at different kind of slices of the brain in a PET study, so looking at brain activity, you can see that when they're watching a nature video, there are areas that are pretty active, and some of that it appears to be the right amygdala and the anterior cingulate. You see some yellow and a teeny bit of red in there, but you can see the change when they start watching the video of someone doing cocaine. The right amygdala has a lot of red, and the anterior cingulate cortex has a lot of red. This is causing a great deal of craving. I have a couple or a few slides here talking about drug abuse and comorbidity. So people who are abusing substances and they also have some kind of psychological disorder, mental illness, or maybe a learning disorder. And it is very likely that those people abuse substances at some point, and this might have started out as a kind of self-medication that turned into substance abuse. And again, it's not to give them excuses for abusing substances, but to give us some idea of why we might want to show some compassion and to have some understanding for people who end up in this situation. So if we look at people with schizophrenia, up to half of the people with schizophrenia have a substance abuse disorder. And if we look at the ones who are just smoking cigarettes, 70 to 90% of schizophrenics are nicotine dependent. And so we see this clear comorbidity. I have over in my figure over there the volume of prefrontal gray matter, so the neurons in the prefrontal cortex, the volume of that, and we can see that it's much higher in healthy controls than in either our alcoholic patients or our schizophrenic patients. And when we see these comorbid patients that are both alcoholic and schizophrenic, that's even lower. Okay, and I don't know if I've mentioned before the damage that alcohol does specifically to the prefrontal cortex as we are inhibiting or stopping the NMDA, getting into the NMDA receptor and blocking NMDA, that glutamate, as well as projecting GABA into the prefrontal cortex. I think I talked about this very briefly, how that's working with fetal alcohol syndrome, that we are causing apoptosis. We are causing those neurons to die off, but we can still see that apoptosis in people who are drinking alcohol. Okay, and if we look at smokers with a psychiatric disorder, we see that 7% of the population have a psychiatric disorder. People with psychiatric disorders are 7% of the population of smokers. Get that in the right order. 34. They are smoking 34% of all the cigarettes. So they're likely to be the ones who are chain smoking or smoking more cigarettes than people who then healthy controls. Just looking generally at some other disorders and the likelihood of comorbidity. If we look at people with ADHD, 60 to 89% of them have substance use disorders, often alcohol abuse, sometimes abusing other drugs, often smoking, more likely to smoke cigarettes as well. If we look at people with mood disorders, this is one of the most common psychiatric disorders, comorbid with substance abuse disorders. And alcohol is a depressant, so that can work in either direction. But if I have some kind of mood disorder and I'm drinking, it is not helping me to feel better, that's for sure. And then we have just the generalized anxiety disorder. If we look at their lifetime prevalence of alcohol abuse, about 30 to 35% of them at some point abuse alcohol. Lifetime prevalence of drug abuse and dependence, 25 to 30%. Abusing drugs of some kind at some point during their lives. And I've taken out a couple of slides here about genetics and environmental factors and how they play a role, but both genetic and environmental factors play a role in the likelihood that someone's going to abuse substances. In one study of male twins, they found a strong genetic factor for all categories of drugs, and that it was shared environmental factors that had a stronger effect on use of drugs rather than abuse. So so there was one study looking at home environment and the likelihood of using marijuana. It's likely that we're going to use drugs if they're in our home environment, but that doesn't mean there's not such a clear relationship with the abuse of drugs. In a really neat study that's a reviewed study of twins by Goldman et al., 2005, you can see the heritability estimates for several different kinds of drugs and people being addicted to those drugs. And some of those drugs are less likely to show any addiction anyway, like hallucinogens, but and cannabis, which if any kind of addiction is happening, it's more psychological than physical. But we can also see that some of those drugs and some of those drugs like stimulants and sedatives are much more environmental than necessarily heritable. And as we get into a lot of the drugs that we see as really difficult to deal with the drug abuse, so opiates and cocaine are more heritable than so much environmental. And of course, smoking, alcohol, caffeine, all of those are in between there. If we look specifically at the heritability of alcoholism or abusing alcohol, there's a strong influence of genetics on alcoholism, but really for a particular type of alcoholism, which is an early onset alcoholism. And there's less of a genetic component to the later, more graduate onset. And so researchers have distinguished between two types of alcoholism. Type 1 or type A is a later, more gradual onset, usually after the age of 25, where someone is probably starting to have a drink here and there to deal with stress or whatever, and then slowly adding more and more drinks a night or more and more nights of drinking. Those people have fewer genetic relatives with alcoholism, and we see an equal quantity of both men and women who are in this kind of category, who have this kind of alcoholism. And they usually distinguish that type 1, type A, from type 2 or type B alcoholism, which is an earlier onset before the age of 25, more rapid, where oftentimes they'll start out having a drink and then having several more. So binge drinking when they start drinking in the first place. They tend to have more genetic relatives with alcoholism, and in this case, the men outnumber the women. Your author does talk about Antabuse, so this is the medication that can combat alcoholism. This is really dependent on the person deciding and wanting very badly to quit. What happens when we drink alcohol is that enzymes in the liver metabolize it into acetaldehyde, which is a poisonous substance. It's a substance that is toxic to our bodies. Acetaldehyde is converted by the body by an enzyme called acetaldehyde dehydrogenase into acetic acid. And acetic acid is not only not toxic, it is a chemical that the body can use as a source of energy. But if we have an accumulation of the acetaldehyde, that results in sickness. And they think this is at least partly what is causing hangover and so forth. He also brings up here the fact that they have less alcoholism in Asian countries, and there's a percentage of people of Asian descent who have really, they get sick when they drink alcohol because they're very low in that enzyme, the acetaldehyde dehydrogenase, and so they get this accumulation of acetaldehyde, and you'll start to see a flushed face, their heart will start beating fast, and they'll feel kind of nauseated. That is basically, Antabuse is an antagonist for the acetaldehyde dehydrogenase. So basically, it is making people kind of like they're allergic to alcohol because it's keeping that toxic substance around and not allowing the body to convert it. And so they take the Antabuse, and so if they drink, they start to feel very sick very fast. Most studies suggest that Antabuse has really been only moderately effective in helping alcoholics to quit. And it's really only effective when it supplements the alcoholic's own commitment to quit. Oftentimes, if they really are craving a drink or want to drink, they'll just stop taking the Antabuse so that they can drink. There's also the suggestion that the daily routine of taking a pill may reaffirm their commitment to stop drinking. If we look at the medications used to combat heroin abuse, the most common one, and the one your author talks about, is methadone, which is an opiate similar to heroin and morphine, but it is absorbed and metabolized more slowly. So they're not injecting it, they're not getting that rush. It's perceived to be less harmful than heroin and morphine, and it's assumed that what's happening is we are satisfying the cravings that are associated, because they're still getting the opiate, but it can lessen the withdrawal symptoms because they're still getting the opiate. But because we're not getting the rush, we also aren't seeing quite the craving. One of the problems with methadone is that people who are addicted to heroin and morphine and those kinds of opiates, sometimes they can't get or afford or find what they need to find, and so they'll sometimes go to a methadone clinic kind of in the interim to get methadone, or people will take methadone and still sell it on the street because it still is an opiate, but just with the less of a rush, less of a cravings, and it can help with the withdrawal symptoms. What seems to be even more helpful is this buprenorphine, and we don't have the same problem with it being stolen or people coming in to use it to tide them over until they get their next hit or their next bunch of heroin. This is a partial agonist. It has high affinity and relatively low efficacy. And so they did a study comparing placebos, buprenorphine alone, and then buprenorphine and naloxone. If you remember what naloxone was, it was it goes in and blocks those opiate receptors completely. So that now I take an opiate, or even if I have my endorphins rushing, that it doesn't influence the opiate. The postsynaptic neuron they don't go into that opiate receptor because it's blocked by naloxone, and naloxone is not affecting the postsynaptic neuron. And you can see that really what's helping here is the buprenorphine, though, because that is a partial agonist. They're getting some of that, like methadone, they're getting some influence on those opiate receptors, and yet it's a partial agonist, so it's giving less of an effect on those opiate receptors. And what that means is if I take buprenorphine and I'm having this small effect on my neurons that respond to opiates, I'm not going to have a very strong effect. And now, if I do take methadone, heroin, morphine, or whatever I can get my hands on, it's not going to have any effect either, because I have this buprenorphine, just like naloxone, blocking it, but having this partial effect. So this appears to be helpful and to not have all of the problems that we see with methadone. Okay, that is my discussion of substance abuse. I did want to come back to this idea that of treatment of medications are not necessarily, they are one answer, and they can help people. And sometimes it really does depend on that person wanting help anyway. But at least with the buprenorphine, it can help with the craving. And other things that really help are things like Alcoholics Anonymous, Narcotics Anonymous, cognitive behavioral therapy, some therapy where people are getting some kind of help, and especially the therapy and a medication. If I'm going to take a medication, is more helpful than just taking a medication. This kind of reaffirming the fact that I want to stop using drugs. And there are people who get addicted and have a weak enough kind of dopaminergic reward system, and they get addicted enough, and at a young enough age where they are always, for the rest of their lives, going to deal with handling their cravings. Walking by, I'll use cigarette smoke because it's a likely thing to happen, of just walking by somebody who's smoking cigarettes, and just going, oh, wow, I really want a cigarette now. That's just it becomes part of their lives. Okay, so it's the weekend. I'm pretty sure this is finished. I'm going to do maybe just a little tiny bit on autism spectrum disorder on Monday, and I am hoping people ask questions, and I will look out for those so that I can do a semi-review kind of thing on Monday. Do ask them before Sunday afternoon sometime so that I can plan ahead. All right, have a good weekend. Take care.